Thank you very much, Professor Kalman, Professor Weber, ladies and gentlemen. Good afternoon. It is my great honor to have an opportunity to be a speaker in ZANS and UNDED 2022. My disclosure information. What did we learn during the last 10 years of AF ablation? This is Kaplan-Meier curve of AF recurrence after catheter ablation in my institute. In over 4,000 patients in this cohort, 1 year outcome is pretty good. Over 87% for proximal and 78% for persistent AFib success. However, as patients get older, AF recurrence continuously like this. I think their first AF recurrence 5 years after de novo procedure might be AF progression. Although we can reduce AF burden by catheter ablation, it is not possible to cure this degenerative disease. We know the AF ablation complication risk is higher in women, especially in elderly ladies. In this study, we measured the pulmonary vein antral wall thickness of CT scan and evaluated sex differences in wall thickness and risk of complication. We found that the major complication rate and the risk of tamponade were significantly higher in elderly ladies older than 75 years. And the left and right side antral wall thickness were significantly thinner in those old ladies. We also found AF catheter ablation increased the left atrial pressure at the repeat procedures, especially in patients who underwent empirical extrapulmonary vein LA ablation. We measured the 1 year follow-up echo parameter instead of invasive LA pressure measurement in this study. And the stiff LA physiology was observed in 3.7% of overall patients after ablation and was associated with diabetes and high EOB prime, underlying diastolic dysfunction, and empirical extrapulmonary vein LA ablation. Therefore, we have to be very careful to do extra PV ablation without any significant evidence. This is 2017 HRS ERA APHRS guidelines for extra PV ablations. Reproducible focal trigger ablation is a class 2A indication, but linear ablation, voltage-guided ablation, cafe ablation, foam ablation, or GP ablation are classified as class 2B indications. Okay, now let me get to the point of today's topic, extra PV triggers. We do not conduct the empirical extra PV lines or cafe anymore because we failed all the randomized clinical trials for empirically conducted extra PV ablations. But extra PV provocation and trigger ablation is a routine procedure after PV isolation. Let me show our protocol to provoke extra PV foci. At the basic ablation protocol, we give isoproterenol 3 to 20 mic per minute until the heart rate exceeds 120 BPM. We try to keep the target sinus heart rate 120 because isoproterenol dosage varies depending on the beta blocker use. Unlike the report from the Western countries, some small body-sized Asian patients easily show hypotension or vomiting during isoproterenol provocation. So after reaching the heart rate 120 beats per minute, we induce atrial fibrillation or atrial tachycardia by ramp pacing from 250 to 120 millisecond pacing cycles. If we fail to induce sustaining atrial fibrillation 3 times, we stop isoprel and wait for 10 minutes of cooling down period. After successful AF induction, we maintain atrial fibrillation or tachycardia for 3 minutes until intracellular calcium elevation, keeping the isoproterenol. After 3 minutes ongoing atrial fibrillation under isoproterenol, we deliver the internal cardioversion 10 to 20 joule to restore sinus rhythm. When you try to map the extra PV foci, it is a challenging situation if high energy cardioversion shakes the 3D geometry. Therefore, optimal electrode position and good tissue contact are essential to map the reproducible extra PV triggers with the lowest energy. And after internal cardioversion, we wait for 10 minutes of isoproterenol cooling down period. If there is no trigger, we finish the case. But if there are a consistent APC and immediate recurrence of atrial fibrillation trigger, we try to map and eliminate it as much as we can. Because we already isolated pulmonary veins, this ERAP must be an extra PV trigger. Therefore, mapping catheter position and 3D standby are very important for this extra PV trigger mapping. In this case, we could detect non-sustained atrial tachycardia or the frequent APC from SVC catheter here. And the SVC is one of the most commonly found extra PV trigger sites in Yonsei University AF cohort, 11% of overall extra PV foci. And repetitive shock and extra PV mapping is painful and stressful procedure requiring deep sedation and risk of complication. However, if it shows the reproducible and consistent pattern, you can map carefully and ablate them all by using 3D mapping. Some of the EP labs use adenosine to provoke the extra PV triggers. In this study, Tutuyano compared the effects of isoproterenol and adenosine in 40 patients with proximal AFib. At the same condition, isoproterenol provoked the extra PV trigger in 7%, but adenosine induced over 50%, mostly from RA and chronic sinus. However, adenosine-induced non-PV trigger did not show any prognostic value in this study. Now, where are the location of extra PV triggers in the de novo procedures? This is a St. Angeles report, and there were 11% of extra PV triggers, regardless of proximal, persistent, or long-standing persistent AFib. And common sites of extra PV foci were SVC, crista, mitral annulus, and ligament Marshall. Ikenochi classified the location of extra PV foci depending on LA volume index, and they counted the AF trigger foci and non-PV AP atrial premature beat altogether. In this study, the proportion of non-PV foci was significantly higher in AF patient with larger left atrial size than smaller one, and it was consistent in interatrial septum, CS, or left atrium. However, SVC trigger was more commonly found in smaller LA patients exceptionally. This finding was consistent with Taiwan report that SVC trigger was commonly found in younger patients with small LA size. This study systematically reviewed extra PV triggers at de novo and redo procedures in over 2,000 patients with isoproterenol provocation, and we found extra PV trigger in 12% of de novo and 29% of redo procedures. The most common site of extra PV trigger were septum, chronic sinus, and SVC, but less commonly found in LA posterior wall or appendage. During isoproterenol cooling down period, you can apply 3D quick map using the multi-electrode catheter to localize extra PV foci. However, you need to make sure extra PV foci localized in 3D map is the endocardial exit site. Sometimes it comes from epicardial layer away from the endocardial exit site. Then, is this complicated and stressful mapping procedure for extra PV foci really valuable during repeat procedures? We previously reported isoproterenol provocation and trigger ablation shows a better rhythm outcome than just finishing the case without isoproterenol provocation. However, those with extra PV trigger shows the worst rhythm outcome than those without trigger, even after additional ablation. And Professor Young Kim's group published excellent randomized clinical trial, which proved the value of isoproterenol provocation and extra PV trigger ablation. In this study, elimination of extra PV trigger improved the long-term rhythm outcome after AF ablation. In this study, Tohoku provoked extra PV foci by isoproterenol and adenosine and tried to eliminate all the extra PV trigger, even atrial premature beats. After this aggressive protocol in 300 patients with persistent AFib, the rhythm outcome was equivalent in those without extra pulmonary vein foci. However, the recurrence rate was significantly higher in patients with remaining extra PV foci or atrial premature beats. This study compared the ablation outcome depending on diagnosed to ablation time difference. As we expected, the earlier ablation group showed a better rhythm outcome. The interesting finding of this study was the existence of a non-PV trigger shows a worse rhythm outcome, but not the non-PV atrial premature beat alone did not. This study compared the outcome of a cryoballoon ablation and radiofrequency wide circumferential PV isolation in 1,500 patients with proximal AFib. Although rhythm outcome did not differ between two groups, RF Walker group shows a more enterally directed ablation. In the repeat ablation procedures, PV reconnection rate was significantly higher in RF group than in cryo group, but non-PV trigger was more commonly found in cryo group than in RF group, especially in left atrium. Probably in those areas, there was extra PV triggers. Now, I would like to mention the role of extra PV triggers proven during the repeat procedures. Does the number of reconnected PV potential affect the outcome of second procedure? The answer is yes. In this study, 37% of patients maintained the PV isolation at repeat procedure in spite of recurrence. And the outcome of second procedure was worse in those patients without PV reconnection than those with PV reconnection. And this outcome reflects the contribution of extra PV foci as the mechanism of long-term recurrence. We also proved the reduced number of PV reconnections as later timing of recurrence after de novo procedure, and recurred within a year and between 1 and 3 years and after 3 years. And as the recurrent timing was later, the proportion of extra PV trigger were lower in the de novo procedure. However, when those recurred patients underwent rhythm mapping, the extra PV trigger was most commonly found in patients with later recurrence after 3 years. These findings suggest that PV-AF progression and the extra PV trigger contribute to delayed recurrence after 3 years of de novo ablation. I showed this slide before, and we found extra PV triggers in 12% of de novo and 29% of redo procedures. And the most common side of extra PV triggers were like especially in septum and SVC. More importantly, over 30% of extra PV foci mapped at the redo procedure matched with previous empirical ablation sites. Over 30% of extra PV foci during the redo procedure matched with previous empirical ablation sites. As you expected, rhythm outcome was worse in patients with extra PV trigger in both de novo and repeat procedures, and it was even worse in patients with multiple extra PV triggers than in those with single triggers. Many people believe early recurrence after AF ablation is due to procedure-related inflammation and do not consider as a real clinical recurrence. In this study, with over 2,000 patients who underwent consistent isoprotein provocation protocol, we compared the early recurrence alone, late recurrence alone, and late recurrence after early recurrence. And the 56% of patients with early recurrence eventually recurred as a late recurrence. And the long-term outcome, in the long-term outcome, the patients who experienced early recurrence showed significantly worse rhythm outcome. And the repeat procedure, rhythm outcome was especially worse in patients with early recurrence and extra PV triggers. So the mechanism of early recurrence includes, number 1, transient inflammatory factor, number 2, acute PV reconnection, and number 3, extra PV triggers. Among them, extra PV trigger seems to have a worse effect after repeat procedures. We also analyzed characteristics of patients who recurred the first time 5 years after the de novo AF ablation. At the repeat mapping procedure, we found extra PV trigger play essential role in those patients with very, very late recurrence after 5 years. I'm not sure it is appropriate to say them as 5-year recurrence or new AF generation by AF progression. As you know, the AF ablation rhythm outcome is worse in women after both de novo and the repeat procedures. In this Cox regression analysis, worse rhythm outcome of a redo ablation was independently associated with women, non-proximal AFib, and extra PV triggers. So women and extra PV triggers are poor prognostic factor together after catheter ablations. What about the antiarrhythmic drug response in patients who recurred after catheter ablation? There is also sex difference in AAD responses, and women and elderly patients over 60 years shows a better rhythm control response to antiarrhythmic drug. These findings suggest AAD might be effective in controlling extra PV triggers. We know there are higher chance of extra PV trigger at the condition of acquired atrial structure remodeling. However, extra PV trigger also have a genetic background. Recently, we found the zinc-finger-Homburg-3 gene, which is a top second AF-associated genome, has a significant relationship with extra PV triggers. A zinc-finger-Homburg-3 gene has functions for inflammation, fibrosis, and matrix remodeling. Lastly, I would like to briefly mention the role of Bachmann's bundle as a potential extra PV trigger. And Bachmann's bundle is an epicardial muscular bundle connecting right atrium high crista to left atrial appendage ridge. It provides electrical conduction highway between sinus node to left atrium. And as shown in this specimen, it has about 4 millimeter thickness, 9 millimeter height from the endocardial surface, 10 millimeter upper length, and 3 millimeter lower length. Bachmann's bundle is composed of 5 different cellular structures, including arrhythmogenic P cells, and it has embryological similarity with sinus node in his bundle, and different shape of action potential curve with steeper upstroke, pointed overshooting, shorter plateau, and higher resting membrane potential comparing with working myocardium. The most special electrophysiology of a Bachmann's bundle is much faster, but with different conduction velocity at the superficial and deep layers. Therefore, significant layer-dependent conduction difference and automaticity have Bachmann's bundle an arrhythmogenic structure in some patients with structural remodeling. We need to make sure the vascular anatomy of Bachmann's bundle is close to the sinus nodal artery from RCA and ramus branch from left circumflex coronary artery. Therefore, we experience Bachmann's bundle origin ectopic atrial tachycardia during AF ablation in some patients. And this tachycardia seems like the high septal focus, but was entrained from both left and right side high septum. So we assume the mechanism of this tachycardia as a micro reentry involving Bachmann's bundle and both side high septum. But it is not easy to eliminate this tachycardia because Bachmann's bundle locates on the epicardial side, including sinus nodal coronary artery. This is another example of a Bachmann's bundle origin extra PV trigger after PV isolation. During isoproton provocation, we observed the reproducible AF trigger, and SVC proximal electrode shows the earliest activation, and NAVIX map shows the earliest activation at the right atrial high septum. During RF delivery at the RA high septum, AF terminated and restarted repeatedly. Therefore, we ablated from both left and right side of high septum, and the tachycardia eventually terminated after burning around the endocardial contact area of Bachmann's bundle. So I think this third fat pad at the junction between SVC and aorta also plays some role in this high septal Bachmann's bundle tachycardia by autonomic neural activation. So in conclusion, ladies and gentlemen, atrial fibrillation is not a curable disease, and the empirical extra PV LA ablation should refrain without clear evidence. And extra PV triggers with genetic background play a major role in AF recurrence after catheter ablation, especially in women and the patient with early recurrence or AF progression. Isoproteral provocation and extra PV trigger ablation are valuable to improve the rhythm outcome of AF ablation, and Bachmann's bundle is one of the challenging targets of extra PV triggers from high septum. Thank you very much for your attention, and I would like to express my gratitude to my team, colleagues, and ex-fellows and collaborators. Thank you very much.